Welcome back. Chapter 2, Part 2. Talking about reproductive anatomy and the menstrual cycle. This is the difficult part of the lecture. This is the stuff you've never encountered before. This is the stuff we've been preparing for. We had an entire fundamental lecture to go along with this. And because of that, the room has cleared out a little bit. So you guys are the real troopers. You guys have stayed, and you will reap the rewards. I promise you. You will be good. And to the men, I expect to see you at dinner tonight. I forgot to do my whole intro. Guys, thank you so much for supporting the channel. Thank you for watching. I really hope you're studying hard, and I hope that you're benefiting from all of this content. We have a lot of links in the description. Go check them out. And if you donate through the link in the description, 50% of what you donate goes to Doctors Without Borders. Thank you guys so much. Hope you enjoyed the video. Reproduction is a necessary part of humanity. We need to be able to pass on genes. Now, someone made a comment before. A very smart man sitting in the front told me, you're not talking about the specific vocabulary of the meiosis, the tetrads and like the other words that I completely forgot. Number one, very, very, very hardly do I hear people comment and being like, what's a tetrad? There's diagrams, there's animations, we go over the basic information, you go to the Anki, it tells you what a tetrad is. You see it right there in front of you. It is not my business to get into the weeds of the discussion. At least not with stuff like this. When we get to organic chemistry and biochemistry, I will get into such tough weeds of the discussion that you will wish that I just threw a blanket over you. I will be so critical and so destructively dissecting that topic that you will wish you never stepped foot into this room. I'm telling you that much. I will tell you specifics about the mechanistic actions of each and every single one of the enzymes that we will encounter, their cofactors, the different electrophilicity profiles, the reason that one system is preferred over the other, because I want you to look at a reaction and be like, oh, I know what happens here. Done. I don't care if you know what a tetrad is. You can probably take a guess, right? By the way, for sake of completion, a tetrad is the thing that forms when the two homologous chromosomes come together for crossing over. That's a tetrad. You have chromosome, chromosome, you smash them together to cross over, that's a tetrad. Okay. I would be more surprised if one of you could tell me why magnesium ion is the cofactor of hexokinase and how it helps with the phosphorylation of glucose. And relate this over to a tetrahedral carbonyl addition intermediate reaction in organic chemistry. If one of you can explain that, I'd be more than happy. Because that's where we're going. Okay. So, 23 pairs of chromosomes, correct? The 23rd pair are known as the sex chromosomes. I remember hearing all the giggles around the room when we talked about that in 9th grade. Like a bunch of 14-year-olds be like, sex. And now we're 25 going, hee-hee, sex. Sex chromosomes. Why? They determine the physiologic and apparent sex of the child and the human being. 2 X chromosomes means you are a female. 1 Y chromosome and 1 X chromosomes means you are a male. I almost said 2 Y chromosomes. Incompatible with life. There are a set of diseases that come from what we call non-disjunction errors, where in metaphase, when the chromosomes come together, they don't properly separate. They don't disjoint. I will teach you about them. Non-disjunction errors come from meiosis, primarily meiosis 1, and most of them happen in females. Why in females? Does anyone know the answer to this question? Why more non-disjunction errors happen in females? when you are making the gametes, the sex cells inside of women, you are actually restarting a cellular process that started when that woman was developing. When a woman is developing inside of her mother as an embryo and a fetus, all of her ova inside of her ovaries have already begun to divide for meiosis. It's already started. And the body halts all of them at one time, throws a blanket over them, says, everyone stop, and stops them right in the middle of meiosis. Right? When the woman later comes of age and puberty begins, the GnRH that we're going to talk about later starts to put out FSH-LH, which instigates a process by which the ova begin to mature again. And the most sensitive ovum is the one that matures first and feeds back and dials down the amount of GnRH, FSH, and LH until it just gets enough response to be the only one that matures. And it goes on from there. Women, all of the women in this room, right, and all of the women on earth have all of the ova they will ever create in their entire life in their bodies right now. And they are all frozen in time from the time that they were fetuses. Incredible. Crazy stuff. But because of that freezing and restarting, errors occur more often, and most of the non-disjunction errors occur in women. Is there any way to fend this off? Is there any way to avoid this? No. So if a child is born with Down syndrome and some idiot comes and tells you it's the mom's fault, slap them. By the way, that happened to a family friend of mine. Their child was born with a severe intellectual disability, and her own father blamed her. It's a tough world out there. Non-disjunction errors can lead to specific changes inside of these sex chromosomes that the MCAT wants you to know. When the 23rd set of chromosomes does not move away properly, you can imagine that we can have a cell that is left with 2 of that chromosome. You can also have a cell that is left with none of that chromosome, correct? If a sperm cell with a normal number of chromosomes combines with a non-disjointed egg cell, right? Because think about it. We're having this, and we want them to move apart. Let's say all of these go in one direction. Now you have an empty cell, and you have something with both of these. Then when that splits, do you guys see the problem? Now that's too many. You guys see that, right? So if a sperm cell fertilizes an egg with 2, a diploid number of the 23rd chromosome, let's say that these are both X, this leads to XXY syndrome, also known as, not intersex, no. What's the name of the disease? A man with extra feminine qualities is Klinefelter syndrome. These men are abnormally tall, have concave chests, very, very large for a man, breasts at puberty, very small testicles, and a bunch of other stuff that you may learn about inside of medical school. Klinefelter syndrome. Mind you, we're talking only about the 23rd pair of chromosomes. There are other non-disjunction errors that happen to other chromosomes. If you're interested, check out trisomy 13, trisomy 21, and trisomy 18. The famous one out of that is trisomy 21, which is Down syndrome. You don't hear about the other ones because they're so deadly.
So you mentioned that how the sperm can bind to a cell that has 2 chromosomes.
Yes.
Is it a possibility for it to bind to the non-disjuncted cell where it has no chromosomes in it?
That's a very good question. Question was, if you can bind to the one with 2, can you bind to the one with none? Yeah, you can. Because it has 22 chromosomes, and then it's missing the 23rd. Just missing, right? If you were to add a chromosome to this, let's say the Y chromosome gets added to this, right? Or sorry, the Y chromosome isn't compatible with life. My bad. But if you add the X chromosome to this, you will get 22 pairs, and then you will get XO. This is known as XO syndrome, also known as, anyone? Reproductive biology. This is called Turner's syndrome. These are your very short-statured women with flat chests and webbed necks. You should look up the phenotype, the way that they look. Klinefelter syndrome and Turner syndrome. Look at the way they look. You will remember it for the rest of your life. And this is how you make associations. You learn, you look at the picture. Yes?
You said that more women have non-disjunction issues.
Yes.
Why is there not a mechanism for the non-disjuncted cells to become polar bodies?
To become polar bodies? That's a good question. I believe that you need 2 X chromosomes to become polar bodies. So like, you could have it here, but that doesn't discount the fact that you're still going to have a man with 2 X chromosomes. Even though one of them is a polar body, you still have a man with 2 X chromosomes. That's still a fact. I don't know about the sort of molecular biology of how all that works, the signaling pathways and whatever it is. There is also XYY syndrome, which became colloquially known as Superman syndrome, because double Y chromosomes, right? Not much to note there. Nothing really happens. I think it shortens the lifespan by a little bit.
So would it be like 2 sperm cells penetrating the same egg cell?
1 sperm cell, non-disjunction. You guys get that? Yes? That is known as sex-linked inheritance. But that's a different type of sex-linked inheritance than the one that happened to me. My grandfather was colorblind because he had a defect on his X chromosome. He had a kid with my grandmother, who is my mom, who is a carrier of this disease. Why does she have it? It's recessive. This is an X-linked recessive disease. You guys have been over this before. Yes? In genetics. X-linked recessive means she doesn't show it, but she carries it. She meets my dad, and if I was going to be a boy, which I am, it's a 50% chance my mom gives me the faulty chromosome. She gave it to me, and I'm colorblind. All the way back from her dad. That's how I got colorblind. Understood? Cool. What % of men in the world are colorblind? I said this one time. Guys, let me tell you a quote by not my old teacher, he's actually my teacher right now. I respect him very much. He told me, you want to know, he gave me such a beautiful word of advice. He said, you want to know the way to succeed in everything in life? How to succeed in everything? I'm going to hide it for a second. Never forget. Don't forget anything and you'll succeed in life. Every single thing you learn, remember it forever. That's how you succeed in life. I've been doing it for all of 3 seconds. Trust me, it's working. All right. You guys ready to go? The Kaplan book makes large, sweeping generalizations sometimes about the amount of things you need to know about something. How much do you need to know about the male reproductive system? Very little. Remember this acronym. 7-Up. Anyone remember that drink from when we were kids? I don't know if anyone drinks it anymore. 7-Up. The pathway by which stuff, sperm, everything, seminal fluid travels inside the man's body. Let's do a little bit of anatomy. Am I in frame?
Yes. Oh, your body's kind of.
That's fine. I don't care about me. I care about the information. You have the testes. Testes have stuff inside of them. They wrap up. They wrap up. They hit this big gland. They go in. They come out. This is the penis. That's it. That's the general anatomy you need to know. We'll go through all of this. The seminiferous tubules. These produce sperm. Where do you think they're located? In the testes. Sperm comes from the testes, right? Seminiferous tubules are the functional units of the testes, which produce sperm, and they're nurtured by a specific type of cell called the Sertoli cell, which we'll talk about when we get to endocrinology. Sertoli was an Italian scientist. Sertoli. And I think he was from the same part of Italy as my roommate. My roommate in medical school, Tony Chillo, if you're watching this, I love you, buddy. I don't know why he would be watching this. Tony, if you're watching this, get a life. Dude's like literally going to be in residency in a few months. We have the epididymis. This is where sperm gain motility. And are stored. The epididymis, guys, we get graphic in this class, right? It's human anatomy. The epididymis is palpable. You can quite literally feel it on top of the testes sometimes. And the fact that you can do that means that when it gets infected, you can actually feel the range of the infection. Epididymitis is an incredibly painful infection of the epididymis, and you can quite literally palpate it, right? By the way, if you look up MCAT male reproductive anatomy, this diagram will show up. It's a very good diagram of everything I'm talking about, much better than what I drew. So look up Kaplan MCAT male reproductive system. There's another part of the testes other than the seminiferous tubules and the Sertoli cells. The interstitial cells of Leydig. Someone did their studying. Sure hope you did. You just took the exam. These produce testosterone. Notice that sperm and testosterone are made by two different types of cells inside of the testes. Yes? This is a wild moment for me. I have never taught a class this large. This is horrifying. I don't know if you guys can tell, there's like beads of sweat dropping down my back right now. Shivering up here. Testosterone and other androgens, right? Male sex hormones. Male is a loose term there, right? Mainly male sex hormones. Because does anyone know anyone with PCOS? Do you guys know someone with PCOS, right? A lot of that is controlled by the overproduction of androgens, right? Specifically one of them, I think, if my memory doesn't fail me, DHEAS, dihydroepiandrosterone sulfate. Okay. When the male sexual response cycle is elicited and ejaculation is imminent, sperm will actually travel from the epididymis through the vas deferens, which is basically this tube I drew here. Vas deferens, so testes, and I guess I should plug these into the epididymis. Testes, epididymis, up the vas deferens, right? And enter the ejaculatory duct, which is located behind the prostate gland. at the back of the prostate gland, at the posterior edge of the prostate gland. If a man lives long enough, what are his chances of developing prostate cancer or prostate hyperplasia? 100%. Every single man who lives long enough will have some level of prostate hyperplasia because your prostate reacts to testosterone and DHT. And because of the constant stimulation by testosterone and DHT, it grows. Yes?
You said people get PCOS and having like a high amount of androgen.
Yes.
So I was asking, how do you lower that amount?
It is not a biologic increase, it is a pathologic increase. It is not physiologic, meaning normally produced within the body, meaning it's normal for that person. It is pathologic, meaning there is something wrong, right? My leg numbness is not because of a change inside my body that causes my leg to go numb. I have a pathologic disc herniation that presses on my spinal cord. There is some imbalance within the person's hormones that causes it to be like that. So in order to reduce it, it requires lifestyle modifications, plus or minus medicine, plus or minus surgery. Notice the order that I said that in. Very critical. Some people like to jump the gun. Ozempic. The N in 7-Up stands for nothing. Literally nothing. Nothing happens there, right? The two ejaculatory ducts from both sides merge to form the urethra. And there is a part of the urethra that passes through the prostate. This is known as the prostatic urethra, the prostatic urethra. And it is the reason that we can have a surgery called a TURP, a transurethral resection of the prostate. You go up the urethra and rip out the prostate tissue to relieve the symptoms of benign prostatic hyperplasia or prostate cancer, to relieve the LUTs, the lower urinary tract symptoms, from compressing the urethra. You guys can do a whole ijtihad of your own about that. Very complicated. Very, very prostate pathology is very complicated. I wouldn't touch it with a 10-foot pole or a 4-inch finger. And finally, your urethra exits through the penis. And that is how ejaculation happens. Along the way, in places you don't necessarily need to know, you have seminal fluid, which mixes with the sperm and nourishes it, correct? And these are produced by seminal vesicles, the prostate gland, and the Cowper's gland, also known as the bulbourethral gland. The Cowper's gland also produces a pre-seminal fluid, colloquially known as precom, right? This is the pre-ejaculate that comes out during the male sexual response cycle when he gets excited. When a man is aroused, you will have pre-ejaculatory fluid that exits from the tip of the penis in order to clear out and clean the pathway for the sperm. Why does this happen? Yes. So what exited through that duct before that probably didn't get cleaned out by the body? Urine. And urine is very acidic and create a hostile environment for the sperm. Sperm are very picky. So the function of the pre-seminal fluid is actually to clear the urethra for the arrival of seminal fluid with sperm later. Does that make sense? This is the job of the Cowper's gland. Are you guys following? Are you guys learning something? Are you guys learning more than you did before? Good. Okay. Semen is just sperm with seminal fluid. It's a very important distinction to make. Semen is just sperm with seminal fluid.
Does the Cowper's gland also produce seminal fluid? Because I thought it was only
I believe it does both. I have to double check for you on that. But the nitty-gritty, the sort of details, don't believe it's very important. But you will see it referred to both. The Cowper's gland, also known as the bulbourethral. I'm very sorry about what I'm about to do. Let's talk about female reproduction. I'm going to institute a rule. If you are sitting in this room, take everything off your table and put it on the floor. You are not allowed to take notes during this part of the lecture. And you must go home and re-watch this when I upload it and take notes at that point. Everything has to be off your table. Screens, laptops, notebooks, everything. Absolutely nothing can be on your table. Because in my first year of teaching, I taught this 4 times to the same group of students. I don't want to do that again. And they were one of the best groups of students I've ever dealt with. You guys need to be dialed into this. Absolutely dialed in. And this is why this portion of the lecture is what we had a 2-hour prerequisite for. Nobody can be writing, looking at, typing, anything. I want you guys to sit back, relax, and watch the show. Ovaries are the main reproductive organ. I will be creating a diagram of what we go over here. These are the ovaries. Am I in frame? That's fine. That's the end of the diagram anyways. Not the end, but that's the outer bound. These ovaries contain thousands of follicles. By the way, if you're at home, this is your first time watching this, you better not be taking notes for your own good. I will find you. I will find you and make sure that you never get to reproduce. That sounds so weird. The follicles are basically just little sacs, right? And they nourish and protect ova, plural of ovum, a single egg cell. You have plenty of them in here. What's the largest cell in the human body? The egg cell. The egg cell is the largest cell in the human body. One egg, one ovum per month is expelled in response to hormonal activity. 1. And a lot of people think it's put directly into the fallopian tube. Is that true? No, it's actually extracted from the ovum, put into the abdominal cavity, and sucked up by the fimbriae of the fallopian tube. What do I mean by that? The ovaries obviously exist inside of the abdomen, like over here and over here, right? Uterus is down here, ovaries are over here, right? And there are ligaments and everything holding them down and connecting them and everything. Okay. You have little arms at the end of the fallopian tubes. And when the ovum exits, it actually goes right here. So it's suspended inside of the peritoneum, the peritoneal cavity, which engulfs all of the peritoneal abdominal organs. Right? The fimbriae pick it up. These are called the fimbriae. The fingers. Pick up the ovum from the ovary, which is filled with follicles. That's going to get in the way. Just remember that. And this is the fallopian tube. Yes? Okay. The highest point of the fallopian tube, I want you guys to remember this from medical school. The highest point of the fallopian tube is the most common site of fertilization. The sperm will swim up the entire reproductive tract over there to fertilize. That's the most common site of fertilization. How do we figure that out? No idea. No clue. This egg will get into the fallopian tube, travel down and down and down. And what am I drawing here? Huh? Oh, wrong way. What is this? Guys, the uterus. Okay. What is that donut-looking thing over there? That is the cervix, which is the outlet from the uterus into the vagina, the vaginal cavity, which is rugated. This is the vagina and the vaginal cavity. Two different things, by the way. Right? The vagina and the vaginal cavity. Insemination happens where we swim through the cervix, up the uterus, towards the fallopian tube to fertilize. Correct? Understood? Yes? All of this is contained in a space probably smaller than both my hands. All of that. Okay. I will not be going over two concepts. I told you, there are certain concepts in this chapter I don't teach. Spermatogenesis and oogenesis. Remember how I said the oocytes, they freeze in time and then they produce and they blah, blah, blah. No. Not my cup of tea. Not in the slightest. I loved my OBGYN rotation. It was great. People were very nice. I was very helpful. It was fantastic. The surgery was exhilarating. Not for me. Cardiology. Let's do the endocrinology. Before puberty, the hypothalamus actually restricts the synthesis of gonadotropin-releasing hormone. It restricts the synthesis of gonadotropin-releasing hormone. If you did not watch the prerequisite lecture, this is where you're going to start to get a little bit lost, but I'll try my best. Because if I explained all of it, we'd be here for another 2 hours. I'm serious. It restricts the synthesis of gonadotropin-releasing hormone. Oh, by the way, I forgot this is another video. Go watch the Fundamentals of Endocrinology lecture and then come back here. It's a 2-hour lecture, by the way. By limiting the synthesis of gonadotropin-releasing hormone, you actually reduce the amount that you actually not even reduce, you don't allow for the production of two things, which are, from last time, follicle-stimulating hormone, FSH, and luteinizing hormone, LH. By not producing this, you actually don't get the ovarian response and uterine response to these two hormones. What are those responses? How does the adult body respond? How does that prepare for pregnancy? What happens when a woman gets pregnant? How does it stop? How does menstruation occur? How does menstruation continue? How does it resolve? And how does pregnancy end? Are the things we're going to talk about in the next 30 minutes. And then we'll be done. And then we'll be done. In order to talk about, actually, just before this, on the point of puberty, for men, it's very simple. Sex-determining region in the Y chromosome activates in development. This leads to the development of testes and this and this and that and blah, blah. And when puberty turns on, testosterone production begins. Boom, done. Men. Simple creatures. The ovaries are derived of the same tissue as the testes, but respond in different ways to the hormones because of the difference in development. The ovaries will produce two things. If testosterone is the main endocrine product within men, creating their secondary sex characteristics and all the sort, what is it in women? Estrogen. Women and their estrogen rule the entire world. In the body, the activation of GnRH will lead to the release of FSH and LH. The FSH will stimulate the ovary to secrete estrogen. The LH we'll talk about later. The estrogen the estrogen does secondary sex characteristics, breast development, female virilization, pubic hair, blah, 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 this is that, everything. The female body habitus. In the same way that testosterone deepens the voice and leads to linear growth and increases muscle mass and leads to male pattern baldness in the future. Correct? Yes? You can make an argument for testosterone makes men more aggressive. Yes? Estrogen has another job. Estrogen thickens the endometrium, which is the uterine lining. It's this thing. This. Estrogen thickens the uterine lining. What is it made of? Mucus, cells, little tiny arteries, like tissues, whatever it is. It's all that stuff all conglomerated together. It's a mess. It is a mess that is perfect, absolutely perfect for the sustenance of life. It is beautifully crafted and beautifully organized and balanced to sustain growth. That's what it is. And the estrogen thickens the endometrium. Notice the wording that I'm using. I said thickens the endometrium. Remember that. Progesterone is actually secreted when the LH hits something known as the corpus luteum, which we will talk about in a little bit. This is basically a dead follicle. And that leads to the release of progesterone. Progesterone has one job. Does anyone know what it is? Protect. Maintain the endometrium. Without estrogen, does progesterone have anything to maintain? No. Without progesterone, does estrogen have anything to build? Yes. But it can't be maintained. You can build it, you can't maintain it. You'll build and shed and build and shed and build and shed and build and shed, and you'll never maintain. Which is why certain abortive therapies for conception completely shut off progesterone. It leads to the shedding of the endometrial layer. I want one person to open up a laptop. You. One person. That you're available to pass around. Are you guys following? Now with that background and the understanding of how the endocrinology works, we can finally talk about the menstrual cycle. We need a place to start. Much like circulation, the menstrual cycle actually doesn't have a beginning and an end point. It is a cycle. You're in a loop. You're in, and you're in, and you're in, and you're in. And at every single point you're in, I want you to look up Kaplan MCAT menstrual cycle diagram. I will show you which one. That one, if it's clear enough. No, it's not.
I might have the book.
Do you have the book?
On my MacBook, yeah. The Bible book.
That's good enough.
Do you need this book?
Can I see it? Getting flashbacks. This one. This diagram on the left page in the middle, I want you guys all to just look at this for 45 seconds while I teach. It's on page 80 of the 2025-2026 book.
Which one?
This. Don't get distracted by it. In order to start somewhere, so I said the menstrual cycle is much like circulation. You have to pick somewhere to start. In circulation, you could start at the right ventricle. You'd say blood's in the right ventricle, where's it going? Yeah, out of the right ventricle, towards the lungs, out of the pulmonary artery, yes, away from the heart, right? And then you go into the lungs, go to the pulmonary vein, left atrium, but you're normally not starting in a random ventricle. For the circulatory system, we start at the vena cava. Right? And for the menstrual cycle, we start at menses. The moment menstruation begins, the bleeding starts. Right? What is the bleeding? It is the shedding of the endometrial layer. At the end of the cycle, at the end of the last cycle, the endometrium is super thick. There's a lot of it. Because of all the estrogen exposure, you've added a lot to the endometrium. Correct? Okay. So we first have something known as the follicular phase. This begins with menstrual shedding / flow. That's when the period starts. It sheds the uterine lining. Whole uterine lining comes out, and it keeps coming out until all of it's gone. Right? This is in response to what? And this is why it's hard to start somewhere. That's actually in response to a loss of the hormones. The hormones get pulled out from under the rug, and then everything starts shedding. So in response to that loss of hormone, which actually had a negative feedback effect, the hormones which had a negative feedback effect, now that negative feedback is gone, we release what? From the hypothalamus. We release GnRH. GnRH release from the hypothalamus yields FSH and LH, follicle stimulating hormone, luteinizing hormone release from the blank pituitary. Blank is anterior. Through the hypophyseal portal system. GnRH gets poured into the vein. The vein passes the pituitary, circles through a second organ system because it is a portal vein, circulates there, has its effect, leads to the synthesis and release of FSH and LH, which are the gonadotropins, hence gonadotropin releasing hormone. Yes? FSH leads to the stimulation of follicles, which does two things. Number one, it matures an egg cell. Number two, this stimulation from FSH secretes estrogen. So while the flow has begun, you've already begun to prepare for the next one. And if you look at the diagram that's going around, you can actually see the estrogen slowly hike up and the endometrial thickness increase. And I'll put all of this on the board and then tell you guys to take a look back once we're done talking. Okay? You'll make sense of it. The estrogen release actually has a negative feedback on this. And I always ask myself, I was like, how are you going to get the stimulation needed to continue to build the endometrial lining and stimulate the ovum if you have negative feedback? It's negative feedback that's proportional to the sensitivity of the ovum. This is something an endocrinologist taught me in medical school. Invaluable information. The ovum actually secretes messenger molecules to say, hey, I'm this mature. More mature ova are more sensitive to FSH and LH and the hormonal responses, which means that you can dial them down while still having the ovum mature. And by continuously dialing down and turning up the maturity of one single egg cell, you make sure that two aren't released at any given time. Isn't that crazy? It's very interesting. You basically turn up the sensitivity on a single ovum while turning down the sensitivity of the hormonal system simultaneously. The estrogen stimulation will stimulate growth of the endometrial lining, glands, and decidua. New player just entered the game. What is the decidua? It is the thick layer of mucus that lines the endometrium. Protection. It's a barrier. Correct? This is why, and it's uncomfortable to speak about because this is very private information, but this is why discharge is famously very mucousy. It's because of the response of estrogen. Okay, so in the beginning, we actually have relatively thin endometrium that just got sloughed off by the body, and estrogen slowly begins to build that back up, just a little bit. Right? Late into the follicular phase, you'll see somewhere in the diagram that the estrogen levels, they climb, and they hit a peak. And when those estrogen levels peak, for a reason that a medical school professor endocrinologist could not tell me, estrogen turns off its negative feedback and becomes positive. Out of nowhere. Why? No clue. But because of the massive amount of estrogen, that feedback is punchy. It's ridiculous. So you get a whole flow of what? Yes? FSH and LH. FSH is whatever. It's been doing its thing in the background the whole time, as much as it can, given the sensitivity and response of the GnRH and how much of it comes down, blah, 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 blah. Remember that negative feedback doesn't mean off, it means toned down, right? After this positive feedback starts, this is the LH spike. This is the LH spike. There are a lot of women in this room. I'm going to ask you all a question that's not personal. But have you guys ever gotten a random, sharp, lasts for a couple hours pain in one side of your abdomen? Randomly, just one side. Lasts a few hours and goes away. That is ovulation. That pain that is roughly 14 days after your last menstrual period, ovulation. It's the rupture of the follicle in response to the spike of LH. The LH spike is what causes ovulation. That pain has a name. It is called Mittelschmerz. You can look it up. Mittelschmerz. Don't look it up now. Look it up later. It's called Mittelschmerz, right? And a lot of women, not now, a lot of women will come into the emergency room saying, I have right-sided pain in my abdomen. I think I have appendicitis. And the first question they ask is, when was your last period? And they say 14, 15 days ago. That's Mittelschmerz. Or appendicitis. So either it's fine or it'll kill you. The LH spike leads to the release of the mature ovum. Mature from what? Mature from the hormonal reaction that we had before during the follicular phase, where we were dialing up the sensitivity of that ovum, making it mature, 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 and now the LH spike says, go, out. The follicle houses the ovum. The ovum exits the follicle, and the follicle ruptures. The ruptured follicle is now known as the corpus luteum. How are we going to remember that? It ruptured in response to the LH spike. The luteinizing hormone spike made the corpus luteum. This used to be the follicle. After the exit of the ovum, it is the corpus luteum. It stays behind in the ovary, responding to the LH. Yes? Are you guys following? So, estrogen hits a peak. Positive feedback instead of negative. Hits the hypothalamus. Massive kick of GnRH. Even more massive kick of FSH and LH. LH spike, ovulation, formation of the corpus luteum, ow. Okay? Sharp little pain. Now, we were in the follicular phase. We are now in the luteal phase. Can I erase this? Why am I asking? You guys aren't writing anything. Are you guys following? Yes?
So is ovulation a part of the luteal phase?
Huh?
Or is it its own?
It is the bridge.
It's a bridge.
It is the bridge. I am struggling to find a way to explain that. Follicular, luteal, ovulation. As far as I know. The luteal phase. LH stimulates the corpus luteum, ruptured follicle, which leads to the release of progesterone. Very good. Estrogen's in the back doing its thing, getting this ready for an incoming pregnancy. Building, 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 building. Progesterone is maintaining that process. The LH stimulates the corpus luteum to release progesterone that says, hey, it's okay. I know you did all this work. I'm going to hold the fort. We're good. We are ready. Because now is the time to hold the whole thing together. You just ovulated. There's a possibility that if sexual intercourse and insemination occurs, fertilization occurs. And if you can't hold all that together, then all the work was for nothing. Because it's going to shed before the fertilization occurs. Hold together. There is a complex pattern of positive and negative and positive and negative and positive and negative feedback of the FSH and LH, the gonadotropins releasing from the pituitary gland, right? There's a complex oscillation of the hormones, but you can say that the hormones are at a high level throughout this phase. Correct? Yes?
If the luteal phase is maintaining what was done in ovulation, is fertilization, like the likelihood of fertilization the same between both phases?
No, because you can't ovulate if there's not an egg to ovulate. You can't fertilize if there's not an egg to fertilize.
So you can't, wait, I thought you said that you can fertilize during the luteal phase.
You can, not during the follicular phase.
No, that's what I was asking. In the luteal phase and ovulation,
Yeah.
is the likelihood the same or is it different?
So there's a couple days, like sort of bridge. Normally, like the highest fertility for a woman is within a certain period of days that surrounds ovulation. Because the sperm can actually survive inside of the canal and the fallopian tube is quite long, right? And mind you that as the sperm is traveling to the egg is traveling to the sperm, right? Okay. Okay. The corpus luteum continuously releases progesterone. And this has some negative feedback on the whole system. And it's maintaining the endometrial lining, which has been built to a certain degree in order to hold on to and sort of have an egg inside of it, a fertilized egg that will grow. That's the end of the story. This continues until one of two things happens. What's the first thing? One of them, no fertilization. One of them, fertilization. I want you to keep in mind one thing I wrote on the board. If a couple days later, or a week later, however long later, that this is happening, this is still tiny bit being built, still being maintained, still this, still that, no fertilization occurs, no baby, right? This is very complicated. Lock in. The corpus luteum eventually desensitizes to LH. It says, nah, I'm done with you. You're boring. This chain of command right here, I'm going to write it right here, LH. Where was this from? GnRH. Hypothalamus, GnRH. Anterior pituitary, LH. Corpus luteum, progesterone. Keep in mind that negative feedback arrow. Keep that in mind. Okay? Eventually desensitized to LH. Corpus says, I'm tired of you. And this line is cut. Okay? LH is there. It's being produced to whatever level given the feedback. But the corpus gives up. And if the corpus gives up, the progesterone gives up. And if the progesterone gives up, what happens to the lining? This leads to a decrease in progesterone, which leads to the shedding of the endometrium because you're no longer maintaining it, which leads to menses. Back where we started. Now, do you guys remember how I said you pull the rug out from underneath the hypothalamus and everything restarts? I said pay very close attention to the negative feedback arrow. If there's no progesterone, there's no negative feedback, and you can produce as much GnRH as you'd like. And that restarts the cycle. The FSH goes up. The FSH hits the ovary. The ovary matures the ovum. The ovary and the ovum produce the estrogen. And while this is shedding, it's being rebuilt. After that, you get the growth. It goes up to the maximum point, hits the hypothalamus, positive feedback, get the LH spike, ovulation, corpus luteum, progesterone. Progesterone hits, maintains until it grows tired of the LH, pulls the rug, and you start over again. That's the whole thing. That's it. Easy, yes? Not too bad. Not too bad. We will draw it out in a moment after I tell you the other thing that can happen. Yes?
What does that say in the star on the negative on the right side? The right side.
Where?
The right. Yeah, what does that say?
Negative feedback. And when you pull the progesterone, you pull the negative feedback, which is basically positive. So the GnRH starts over. Okay. What if fertilization occurs? You get formation of a zygote, which burrows into the endometrium. This zygote, as it divides, has a complex interaction with some of the environment of the endometrium that is way above your pay grade. But it leads to the production of a compound known as beta human chorionic gonadotropin, a beta HCG molecule. Beta HCG looks exactly like LH, but the corpus luteum can never yawn at it. The corpus luteum can never get tired of beta HCG. So it will stimulate the corpus luteum, but it'll do it a lot. And the corpus luteum will explode with progesterone. Absolutely ceiling levels of progesterone. Right? More than the woman has ever had probably in her entire life. That maintains the endometrium like a lock on a door. Just, we're locked in. Why? Implantation occurred. There is a growing ball of cells that is soon to become an embryo and a fetus and a child inside of you. We're locked in. And this happens, this beta HCG happens until eventually the formation of the placenta makes the progesterone and maintains it for the rest of the pregnancy. Until the placenta is mature and starts to spit out progesterone to maintain the lining. Which is why if you tap a woman's blood and pull it while she's pregnant, progesterone levels are going to be freaking through the roof. Unreal levels of progesterone. Now, who here is smart? All of you guys are very smart people. Which molecule on the board do you use to test for pregnancy? HCG. That's it right there. Only happens when a zygote will implant into the endometrium. And it is detectable 2 weeks out. So if you are detectable on a urine pregnancy test, you're probably 2 weeks pregnant. The moment you're detectable. Any questions? Yes?
So, like, if a woman's having a miscarriage, like when her beta count goes down to like less than 10,000, so what is causing like is it like the progesterone is leaving the?
One reason for a miscarriage can be progesterone withdrawal. The progesterone just falls out, crashes out for whatever reason, right? That can happen. You remind me of a pathology in medical school. It is a cancer that can form from cells within the interface between the embryo and the mother. And that cancer is known to cause absurd levels of beta HCG. Because they're basically stem cells, right? There's stem cells inside of that little, like, everything's growing, everything's producing whatever it is. Sometimes if a woman has an abortion, a surgical abortion, or a miscarriage, or some abnormal growth, or whatever it is, and the placental tissue doesn't really come out, or the chorionic tissue doesn't come out, right? It's called choriocarcinoma. You can have crazy levels of beta HCG. I'm talking about hundreds of thousands, right? Everyone get that? I'm shot, guys. I'm tired. All right, now everyone, you can reopen your laptops and your books and everything, and please pull up that diagram of the menstrual cycle to follow along when I say it to you one more time. the loss of progesterone leads to hypothalamic release of gonadotropin-releasing hormone, which increases the levels of FSH and LH within the body. The FSH will have positive effects on the ovary, which releases estrogen and matures an ovum, a single ovum, through that sensitivity dial speech that we had, right? The growth of the endometrium in response to estrogen happens, and you slowly get a chronic increase in the level of estrogen to a specific degree. That plateau ceiling of estrogen allows for positive feedback on the hypothalamus, which leads to massive releases of gonadotropin-releasing hormone, which leads to even larger releases of FSH and LH. That LH spike causes ovulation. That ovulation releases the egg into, like we talked about, the fallopian tube, the peritoneal cavity, gets sucked up into the fallopian tube, and waits to be fertilized as it travels down the area, right? The endometrial lining, like we said, is already thick from the activity of estrogen. Now, it is progesterone's job through the action of the ruptured follicle, which turns into the corpus luteum, and the effects of LH on the corpus luteum to release progesterone and maintain the uterine lining. As this happens for days and possibly up to 1.5, 2 weeks, right? The corpus luteum eventually gets tired of LH, stops responding, stops producing the progesterone, which puts us back where we started. The only way to exit this cycle is for, while maintaining the uterine lining, we get implantation, which leads to beta HCG, which stimulates the corpus, which continues to produce progesterone until the placenta is made. Any questions? I did not speak about cancer. The only thing that you need to know is about p53. Modulates DNA sequences and makes sure that they don't go haywire. Let's see if I missed anything else. Oh, menopause. Menopause. As a woman ages, the ovaries are less sensitive to FSH and LH. The ovaries atrophy. You get less estrogen, less progesterone. Menstruation stops. And the increased levels of FSH and LH in blood, because of the reduced availability of estrogen and progesterone, because it's not turning them off, it keeps going, right, leads to menopause. A telltale sign of menopause is wicked high FSH inside of an older woman, right? Because it's trying to stimulate a follicle that is no longer responding. Yes? Does anyone have any questions at all? Speak now or forever hold your peace and let me go. Let me leave. As if someone's forcing me to be here. I love it here, man. Thank you guys so much for watching. Please support the channel, and I'll see you next time.